phosphate in the salvage pathway. The salvage pathway is particularly important in certain tissues such as erythrocytes and brain where de novo, a new synthesis of purine nucleotides is not operative. A defect in the enzyme HGPRT causes Lesch-Nyhan syndrome. Regulation of purine nucleotide biosynthesis. The purine nucleotide synthesis is well coordinated to meet the cellular demands. The intracellular concentration of PRPP regulates purine synthesis to a large extent. This, in turn, is dependent on the availability of ribose 5-phosphate in the enzyme PRPP synthetase. PRPP glutamyl aminotransferase is controlled by a feedback mechanism by purine nucleotides. That is, if AMP and GMP are available in adequate amounts to meet the cellular requirements, their synthesis is turned off at the aminotransferase reaction. Another important stage of regulation is in the conversion of IMP to AMP and GMP. AMP inhibits adenyl succinate synthetase while GMP inhibits IMP dehydrogenase. Thus, AMP and GMP control their respective synthesis from IMP by a feedback mechanism. Conversion of ribonucleotides to deoxyribonucleotides. Synthesis of purine and pyrimidine deoxyribonucleotides occurs from ribonucleotides by reduction at the C2 of ribose moiety Fig. This is catalyzed by a multisubunit 2B1 and 2B2 subunits enzyme, ribonucleotide reductase. Supply of reducing equivalents. The enzyme ribonucleotide reductase itself provides the hydrogen atoms needed for reduction from its sulfhydryl groups. The reducing equivalents, in turn, are supplied by thioredoxin, a monomeric protein with 2 cysteine residues. pH-dependent thioredoxin reductase converts the oxidized thioredoxin to reduced form which can be recycled again and again. Thioredoxin thus serves as a protein cofactor in an enzymatic reaction. Regulation of deoxyribonucleotide synthesis. Deoxyribonucleotides are mostly required for the synthesis of DNA. The activity of the enzyme ribonucleotide reductase maintains the adequate supply of deoxyribonucleotides. Ribonucleotide reductase is a complex enzyme with multiple sites, active site and allosteric sites, that control the formation of deoxyribonucleotides. Degradation of purine nucleotides. The end product of purine metabolism in humans is uric acid. The sequence of reactions in purine nucleotide degradation is given in Fig. 1. The nucleic monophosphates AMP, IMP and GMP are converted to their respective nucleoside forms adenosine, inosine and guanosine by the action of nucleotidase. 2. The amino group, either from AMP or adenosine, can be removed to produce IMP or inosine, respectively. 3. Inosine and guanosine are, respectively, converted to hypoxanthine and guanine purine bases by purine nucleoside phosphorylase. Adenosine is not degraded by this enzyme, hence it has to be converted to inosine. 4. Guanine undergoes deamination by guanose to form xanthine. 5. Xanthine oxidase is an important enzyme that converts hypoxanthine to xanthine, and xanthine to uric acid. This enzyme contains Fad, molybdenum and iron, and is exclusively found in liver and small intestine. Xanthine oxidase liberates H2O2 which is harmful to the tissues. Catalase cleaves H2O2 to H2O and O2. Uric acid 2,6,8-trioxypurine is the final excretory product of purine metabolism in humans. Uric acid can serve as an important antioxidant by getting itself converted non-enzymatically to allantoin. It is that the antioxidant role of ascorbic acid in primates is replaced by uric acid, since these animals have lost the ability to synthesize ascorbic acid. Most animals other than primates, however, oxidize uric acid by the enzyme uricase to allantoin, where the purine ring is cleaved. Allantoin is then converted to allantoic acid and excreted in some fishes. Degradation of allantoic acid may occur to produce urea in amphibians, most fishes and some mollusks and, later, to ammonia in marine invertebrates. Disorders of purine metabolism. Hyperuricemia and gout. Hyperuricemia refers to an elevation in the serum uric acid concentration. This is sometimes associated with increased uric acid excretion, uricosuria. Gout is a metabolic disease associated with overproduction of uric acid. At the physiological pH, uric acid is found in a more soluble form as sodium urate. In severe hyperuricemia, crystals of sodium urate get deposited in the soft tissues, particularly in the joints. Such deposits are commonly known as tophi. This causes inflammation in the joints resulting in a painful gouty arthritis. Sodium urate and/or uric acid may also precipitate in kidneys and ureters that results in renal damage and stone formation. Further degradation of allantoic acid may occur to produce urea in amphibians, most fishes and some mollusks and, later, to ammonia in marine invertebrates. Disorders of purine metabolism. Hyperuricemia and gout. Hyperuricemia refers to an elevation in the serum uric acid concentration. This is sometimes associated with increased uric acid excretion, uricosuria. Gout is a metabolic disease associated with overproduction of uric acid. At the physiological pH, uric acid is found in a more soluble form as sodium urate. In severe hyperuricemia, crystals of sodium urate get deposited in the soft tissues, particularly in the joints. Such deposits are commonly known as tophi. This causes inflammation in the joints resulting in a painful gouty arthritis. Sodium urate and/or uric acid may also precipitate in kidneys and ureters that results in renal damage and stone formation. Treatment of gout. The drug of choice for the treatment of primary gout is allopurinol. This is a structural analog of hypoxanthine that competitively inhibits the enzyme xanthine oxidase. Besides the drug therapy, restriction in dietary intake of purines and alcohol is advised. Consumption of plenty of water will also be useful. The anti-inflammatory drug colchicine is used for the treatment of gouty arthritis. Other anti-inflammatory drugs such as phenylbutazone, indomethacin, oxyphenbutazone, corticosteroids are also useful. Syndrome. This disorder is due to the deficiency of hypoxanthine guanine phosphoribosyltransferase (HGP). Such deposits are commonly known as This is sometimes associated with increased uric hyperuricemia and gout. Hyperuricemia refers to an elevation in the serum uric acid concentration. This is sometimes associated with increased uric acid excretion, uricosuria. Gout is a metabolic disease associated with overproduction of uric acid. At the physiological pH, uric acid is found in a more soluble form as sodium urate. In severe hyperuricemia, crystals of sodium urate get deposited in the soft tissues, particularly in the joints. Such deposits are commonly known as tophi. This causes inflammation in the joints, resulting in a painful gouty arthritis. Sodium urate and/or uric acid may also precipitate in kidneys and ureters that results in renal damage and stone formation. Treatment of gout. The drug of choice for the treatment of primary gout is allopurinol. This is a structural analog of hypoxanthine that competitively inhibits the enzyme xanthine oxidase. Besides the drug therapy, restriction in dietary intake of purines and alcohol is advised. Consumption of plenty of water will also be useful. The anti-inflammatory drug colchicine is used for the treatment of gouty arthritis. Other anti-inflammatory drugs such as phenylbutazone, indomethacin, oxyphenbutazone, corticosteroids are also useful. Syndrome. This disorder is due to the deficiency of hypoxanthine guanine phosphoribosyltransferase, HGPRT, an enzyme of purine salvage pathway, Fig.5. Syndrome is a sex-linked metabolic disorder since the structural gene for HGPRT is located on the X chromosome. It affects only those characterized by excessive uric acid production, often gouty arthritis, and neurological abnormalities such as mental retardation, aggressive behavior, learning disability, etc. Patients of this disorder have an irresistible urge to bite their fingers and lips, often causing self-mutilation. Immunodeficiency disease is associated with purine metabolism. Two different immunodeficiency disorders associated with the degradation of purine nucleosides are identified. The enzyme defects are adenosine deaminase and purine nucleoside phosphorylase, involved in uric acid synthesis. Deficiency of adenosine deaminase ADA causes severe combined immunodeficiency, SCID, involving T-cell and usually B-cell dysfunction. It's explained that ADA deficiency results in the accumulation of DATP, which is an inhibitor of ribonucleotide reductase and, therefore, DNA synthesis and cell replication. The deficiency of purine nucleotide phosphorylase is associated with impairment of T-cell function but has no effect on B-cell function. Uric acid synthesis is decreased and the tissue levels of purine nucleosides and nucleotides are higher. It is believed that DGTP inhibits the development of normal T-cells. Biosynthesis of pyrimidine ribonucleotides. The synthesis of pyrimidines is a much simpler process compared to that of purines. Aspartate, glutamine, amide group, and CO2 contribute to atoms in the formation of pyrimidine ring Fig. Pyrimidine ring is first synthesized and then attached to ribose 5-phosphate. This is in contrast to purine nucleotide synthesis wherein purine ring is built upon a pre-existing ribose 5-phosphate. The pathway of pyrimidine synthesis is depicted in Fig, and the salient features are described below. Glutamine transfers its amido nitrogen to CO2 produce carbamoyl phosphate. This reaction ATP dependent and is catalyzed by cytosomal enzyme carbamoyl phosphate synthetase 2, CPSII. CPS2 is activated by ATP and PRPP and inhibited by UTP. Carbamoyl phosphate synthetase I, CPSI, is a mitochondrial enzyme which synthesizes carbamoyl phosphate from ammonia and CO2 and, in turn, urea. Karyotes have only one carbamoyl phosphate synthetase which is responsible for the biosynthesis of arginine and pyrimidines. Carbamoyl phosphate condenses with aspartate to form carbamoyl aspartate. This reaction catalyzed by aspartate transcarbamylase. Dihydroaromatase catalyzes the pyrimidine ring closure with a loss of H2O. The three enzymes CPS2, aspartate transcarbamylase and dihydroaromatase are the domains, functional units, of the same protein. This is a good example of a multifunctional enzyme. The next step in pyrimidine synthesis is a NAD+ dependent dehydrogenation, leading to the formation of orotate. Ribose 5-phosphate is now added to orotate to produce orotidine monophosphate, OMP. This reaction is catalyzed by orotate phosphoribosyltransferase, or enzyme comparable with HGPRT in its function. OMP undergoes decarboxylation to uridine monophosphate, UMP. Orotate phosphoribosyltransferase and OMP decarboxylase are domains of a single protein. A defect in this bifunctional enzyme causes orotic aciduria. By ATP-dependent kinase reaction, UMP is converted to UDP which serves as a precursor for the synthesis of DUMP, DTMP, UTP and CTP. Ribonucleotide reductase converts UDP to DUDP by a theoretics-independent reaction. Thymidylate synthetase catalyzes the transfer of a methyl group from NS, NLO-methylene tetrahydrofolate to produce deoxythymidine monophosphate, DTMP. UDP undergoes an ATP-dependent kinase reaction to produce UTP. Cytidine triphosphate, CTP, is synthesized from UTP by amination. CTP synthetase is the enzyme and glutamine provides the nitrogen. Regulation of pyrimidine synthesis. In bacteria, aspartate transcarbamylase ATCase catalyzes a committed step in pyrimidine biosynthesis. ATCase is a good example of an enzyme controlled by feedback mechanism by the end product CTP. In certain bacteria, UTP also inhibits ATCase. ATP, however, stimulates ATCase activity. Carbamoyl phosphate synthetase 2, CPS2, is the regulatory enzyme of pyrimidine synthesis in animals. It is activated by PRPP and ATP and inhibited by UDP and UTP. Decarboxylase, inhibited by UMP and CMP, also controls pyrimidine formation. Degradation of pyrimidine nucleotides. The nucleotides undergo similar reactions: dephosphorylation, deamination and cleavage of glycosidic bond, like that of purine nucleotides to liberate the nitrogenous bases cytosine, uracil and thymine. The bases are then degraded to highly soluble products beta-alanine and beta-aminoisobutyrate. These are the amino acids which undergo transamination and other reactions to finally produce acetyl-CoA and succinyl-CoA. Salvage pathway. The pyrimidines, like purines, can also serve as precursors in the salvage pathway to be converted to the respective nucleotides. reaction is catalyzed by pyrimidine phosphoribosyltransferase, which utilizes PRPP as the source of ribose 5-phosphate. J9. Metabolism of vitamins. Vitamins are chemically unrelated organic compounds that cannot be synthesized by humans and, therefore, must be supplied by the diet. Vitamins, folic acid, cobalamin, ascorbic acid, pyridoxine, thiamine, niacin, riboflavin, biotin, and pantothenic acid are classified as water-soluble, whereas for vitamins A, D, K, and E are termed fat-soluble. Figure 1. Vitamins are required to perform specific cellular functions. For example, many of the water-soluble vitamins are precursors of coenzymes for the enzymes of intermediary metabolism. In contrast to the water-soluble vitamins, only one fat-soluble vitamin, vitamin K, has a coenzyme function. These vitamins are released, absorbed, and transported with the fat of the diet. They are not readily excreted in the urine, and significant quantities are stored in the liver and adipose tissue. In fact, consumption of vitamins A and D in excess of the recommended dietary allowances can lead to accumulation of toxic quantities of these compounds. I. Folic acid, or folate, which plays a key role in 1-carbon metabolism, is essential for the biosynthesis of several compounds. Folic acid deficiency is probably the most common vitamin deficiency in the United States, particularly among pregnant women and alcoholics. A. Function of folic acid. Tetrahydrofolate leaves 1-carbon fragments from donors such as serine, glycine, and histidine and transfers them to intermediates in the synthesis of amino acids, purines, and thymine, a pyrimidine found in DNA. B. Nutritional anemias. Anemia is a condition in which the blood has a lower than normal concentration of hemoglobin, which results in a reduced ability to transport oxygen. Anemias, those caused by inadequate intake of one or more essential nutrients, can be classified according to the size of the red blood cells or mean corpuscular volume observed in the individual. Figure 2. Microcytic anemia, caused by lack of iron, is the most common form of nutritional anemia. The second major category of nutritional anemia results from a deficiency in folic acid or vitamin B12. Note, these macrocytic anemias are commonly called megaloblastic because a deficiency of folic acid or vitamin B12 causes accumulation of large, immature red precursors, known as megaloblasts, into the bone marrow. 1. Folate anemia. Levels of folate can be caused by increased demand, for example, pregnancy and lactation, poor absorption caused by pathology of the small intestine, alcoholism, or treatment with drugs that are dihydrofolate reductase inhibitors, for example, methotrexate. Figure 3. A folate-free diet can cause a deficiency within a few weeks. The primary result of folic acid deficiency is megaloblastic anemia, caused by diminished synthesis of purines and thymidine, which leads to an inability of cells to make DNA and, therefore, they cannot divide. It is important to evaluate the cause of the megaloblastic anemia prior to instituting therapy, because vitamin B12 deficiency indirectly causes symptoms of this disorder. And neural tube defects in the fetus, spina bifida and anencephaly, the most common neural tube defects, affect approximately 4,000 pregnancies in the United States annually. Folic acid supplementation before conception and during the first trimester has been shown to virtually eliminate the defects. Therefore, all women of childbearing age should consume 0.4 rag per day of folic acid to reduce the risk of having a pregnancy affected by neural tube defects. Adequate nutrition must occur at the time of conception because critical folate-dependent development occurs in the first weeks of fetal life, at a time when many women are not yet aware of their pregnancy. The U.S. Food and Drug Administration has authorized the addition of folic acid to enriched grain products, resulting in a dietary supplementation of about 0.1 rag per day. It is estimated that this supplementation will allow approximately 50% of all reproductive-aged women to receive 0.4 milligrams of folate from all sources. However, folic acid intake should not exceed approximately 1 rag per day to avoid complicating the diagnosis of vitamin B12 deficiency. 2. Cobalamin, vitamin B12. Vitamin B required in humans for 2 essential enzymatic reactions, the synthesis of methionine and the isomerization of methylmalonyl-CoA that is produced during the degradation of some amino acids, and fatty acids with odd numbers of carbon atoms. Figure 5. When vitamin is deficient, abnormal fatty acids accumulate and become incorporated into cell membranes, including those of the nervous system. This may account for some of the neurologic manifestations of vitamin B12 deficiency. A. Structure of cobalamin and its coenzyme forms. Cobalamin contains a car-and-ring system that differs from the porphyrins in that 2 of the pyrrole rings are linked directly rather than through a methane bridge. Cobalt is held in the center of the car-and-ring by 4 coordination bonds from the nitrogens of the pyrrole groups. The remaining coordination bonds of the cobalt are with the nitrogen 5,6-dimethylbenzimidazole and with cyanide in commercial preparations of the vitamin in the form of cyanobalamin. Figure 6. The coenzyme forms near 5'-deoxyadenosyl-cobalamin, in which cyanide is replaced with 5'-deoxyadenosine, forming an unusual carbon-cobalt bond, and methylcobalamin, in which cyanide is replaced by a methyl group. See Figure 6. B. Distribution of cobalamin. Vitamin B12 is synthesized only by microorganisms. It is not present in plants. Animals obtain the vitamin preformed from their natural bacterial flora or by eating foods derived from other animals. Cobalamin is present in appreciable amounts in liver, whole milk, eggs, oysters, fresh shrimp, pork, and chicken. C. Folate trap hypothesis. The effects of cobalamin deficiency are most pronounced in rapidly dividing cells, such as the erythropoietic tissue of bone marrow and the mucosal cells of the intestine. Such tissues need both the N5-10-methylene and N10-formal forms of tetrahydrofolate for the synthesis of nucleotides required for DNA replication. However, in vitamin B12 deficiency, the NS-methyl form of tetrahydrofolate is not efficiently used. Because the methylated form cannot be converted directly to other forms of tetrahydrofolate, the N5-methyl form accumulates, whereas the levels of the other forms decrease. Thus, cobalamin deficiency is hypothesized to lead to a deficiency of the tetrahydrofolate forms needed in purine and thymine synthesis, resulting in the symptoms of megaloblastic anemia. D. Clinical indications for vitamin B12. Other water-soluble vitamins, significant amounts 4 to 5 rag of vitamin B12 are stored in the body. As a result, it may take several years for the clinical symptoms of B12 deficiency to develop in individuals who have had a partial or total gastrectomy, who, therefore, become intrinsic factor deficient and can no longer absorb the vitamin. 1. Pernicious anemia. Vitamin B12 deficiency is rarely a result of an absence of the vitamin in the diet. It is much more common to find deficiencies in patients who fail to absorb the vitamin from the intestine, resulting in pernicious anemia. The disease is most commonly a result of an autoimmune destruction of the gastric parietal cells that are responsible for the synthesis of a glycoprotein called intrinsic factor. Normally, vitamin B12 obtained from the diet binds to intrinsic factor in the intestine, figure 7. The cobalamin, intrinsic factor complex travels through the gut and eventually binds to specific receptors on the surface of mucosal cells of the ileum. The cobalamin is transported into the mucosal cell and, subsequently, into the general circulation, where it is carried by B12 binding proteins. Lack of intrinsic factor prevents the absorption of vitamin B12, resulting in pernicious anemia. Patients with cobalamin deficiency are usually anemic, but later in the development of the disease they show neuropsychiatric symptoms. However, central nervous system (CNS) symptoms may occur in the absence of anemia. The CNS effects are irreversible and occur by mechanisms that appear to be different from those described for megaloblastic anemia. The disease is treated by giving high-dose B12 orally, or intramuscular injection of cyanobalamin. Therapy must be continued throughout the lives of patients with pernicious anemia. Note: folate administration alone reverses a hematologic abnormality and, thus, masks the deficiency, which can then proceed to severe neurologic dysfunction and pathology. Therefore, megaloblastic anemia should not be treated with folic acid alone, but rather with a combination of folate and vitamin B12. 3. Ascorbic acid, vitamin C. The active form of vitamin C is ascorbate acid, figure 8. The main function of ascorbate is as a reducing agent in several different reactions. Vitamin C has a well-documented role as a coenzyme in hydroxylation reactions. For example, C has a well-documented role as a coenzyme in hydroxylation reactions, for example, hydroxylation of prolyl and lysyl residues of collagen. Vitamin C is, therefore, required for the maintenance of normal connective tissue, as well as for wound healing. Vitamin C is, therefore, required for the maintenance of normal connective tissue, as well as for wound healing. Vitamin C also facilitates the absorption of dietary iron from A. Deficiency of ascorbic acid. Deficiency of ascorbic acid results in scurvy, a disease characterized by sore, spongy gums, loose teeth, fragile blood vessels, swollen joints, and anemia. Many of the deficiency symptoms can be explained by a deficiency in the hydroxylation of collagen, resulting in defective connective tissue. B. Prevention of chronic disease. Vitamin C is one of a group of nutrients that includes vitamin E and 13-carotene, which are known as antioxidants. Consumption of diets rich in these compounds is associated with a decreased incidence of some chronic diseases, such as coronary heart disease and certain cancers. However, clinical trials involving supplementation with the isolated antioxidants have failed to determine any convincing beneficial effects. IV. Pyridoxine, vitamin B6. Vitamin B6 is a collective term for pyridoxine, pyridoxal, and pyridoxamine, all derivatives of pyridine. They differ only in the nature of the functional group attached to the ring, figure 10. Pyridoxine occurs primarily in plants, whereas pyridoxal and pyridoxamine are found in foods obtained from animals. All three compounds can serve as precursors of the biologically active coenzyme, pyridoxal phosphate. Pyridoxal phosphate functions as a coenzyme for a large number of enzymes, particularly those that catalyze reactions involving amino acids. A. Clinical indications for pyridoxine. Isoniazid isonicotinonic acid hydrazide, a drug frequently used to treat tuberculosis, can induce a B6 deficiency by forming an inactive derivative with pyridoxal phosphate. Dietary supplementation with B6 is, thus, an adjunct to isoniazid treatment. Otherwise, dietary deficiencies in pyridoxine are rare but have been observed in newborn infants fed formulas low in vitamin B6, in women taking oral contraceptives, and in alcoholics. B. Toxicity of pyridoxine. Neurologic symptoms have been observed at intakes of greater than 2 grams per day. Substantial improvement, but not complete recovery, occurs when the vitamin is discontinued. D-thiamine, vitamin B1. Thiamine pyrophosphate TPP is a biologically active form of the vitamin, formed by the transfer of a pyrophosphate group from ATP to thiamine, figure 11. Pyrophosphate serves as a coenzyme in the formation or degradation of alpha-ketals by transketolase, figure 12a, and in the oxidative decarboxylation of alpha-keto acids, figure 12b. Impaired cellular function. 1. Beriberi. This is a severe thiamine deficiency syndrome found in areas where polished rice is a major component of the diet. Signs of infantile beriberi include tachycardia, vomiting, convulsions, and, if not treated, death. The deficiency syndrome can have a rapid onset in nursing infants whose mothers are deficient in thiamine. Adult beriberi is characterized by dry skin, irritability, disorderly thinking, and progressive paralysis. 2. Wernicke-Korsakoff syndrome. In the United States, thiamine deficiency, which is seen primarily in association with chronic alcoholism, is due to dietary insufficiency or impaired intestinal absorption of the vitamin. Alcoholics develop Wernicke-Korsakoff syndrome, a deficiency state characterized by apathy, loss of memory, and a rhythmical to and fro motion of the eyeballs. P. Niacin. Niacin, or nicotinic acid, is a substituted pyridine derivative. The biologically active coenzyme forms are nicotinamide adenine dinucleotide, NAD+, and its phosphorylated derivative, nicotinamide adenine dinucleotide phosphate, NADP+, figure 13. Nicotinamide, a derivative of nicotinic acid that contains an amide instead of a carboxyl group, also occurs in the diet. Nicotinamide is readily deaminated in the body and, therefore, is nutritionally equivalent to nicotinic acid. NADP plus service coenzymes in oxidation reduction reactions in which the coenzyme undergoes reduction of the pyridine ring by accepting a hydride ion, hydrogen atom plus 1 electron, figure 14. Reduced forms of NAD plus and NADP plus are NADH and NADPH, respectively. A. Distribution of niacin. Niacin is found in unrefined and enriched grains in cereal, milk, and lean meats, especially liver. Limited quantities of niacin can also be obtained from the metabolism of tryptophan. Note, the pathway is inefficient in that only about 1 mg of nicotinic acid is formed from 60 mg of tryptophan. Further, tryptophan is metabolized to niacin only when there is a relative abundance of the amino acid, that is, after the needs for protein synthesis and energy production have been met. B. Clinical indications for niacin. 1. Deficiency niacin. A deficiency of niacin causes pellagra, a disease involving the skin, gastrointestinal GI tract, and CNS. Symptoms of pellagra progress through the 3 Ds, dermatitis, diarrhea, dementia, and, if untreated, death. 2. Treatment of hypopidemia. Niacin, at doses of 1.5 grams per day or 100 times the RDA, strongly inhibits lipolysis in adipose tissue, the primary producer of circulating free fatty acids. The liver normally uses these circulating fatty acids as a major precursor for triacylglycerol synthesis. Niacin causes a decrease in liver triacylglycerol synthesis, which is required for very low-density lipoprotein (VLDL) production. Low-density lipoprotein (LDL), the cholesterol-rich lipoprotein, is derived from VLDL in the plasma. Thus, both plasma triacylglycerol in VLDL and cholesterol in VLDL and LDL are lowered. Therefore, niacin is particularly useful in the treatment of type Lib hyperlipoproteinemia, which both VLDL and LDL are elevated. 7. Riboflavin, vitamin B2. The two biologically active forms are flavin mononucleotide FMN and flavin adenine dinucleotide FAD formed by the transfer of an AMP moiety from ATP to FMN, figure 15. FMN and FAD are each capable of reversibly accepting 2 hydrogen atoms, forming FMNH2 or FADH2. And FAD are bound tightly, sometimes covalently, to flavoenzymes that catalyze the oxidation or reduction of a substrate. Riboflavin deficiency is not associated with a major human disease, although it frequently accompanies other vitamin deficiencies. These symptoms include dermatitis, chylosis fissuring at the corners of the mouth, and glossitis, the tongue appearing smooth and purplish. 8. Biotin. Biotin is a coenzyme in carboxylation reactions, in which it serves as a carrier of activated carbon dioxide. Biotin is covalently bound to the epsilon amino groups of lysine residues of biotin-dependent enzymes, figure 16. Biotin deficiency does not occur naturally because the vitamin is widely distributed in food. So, a large percentage of the biotin requirement in humans is supplied by intestinal bacteria. However, the addition of raw egg white to the diet as a source of protein induces symptoms of biotin deficiency, namely, dermatitis, glossitis, loss of appetite, and nausea. Raw egg white contains a glycoprotein, avidin, which tightly binds biotin and prevents its absorption from the intestine. However, with a normal diet, it has been estimated that 20 eggs per day would be required to induce a deficiency syndrome. Thus, inclusion of an occasional raw egg in the diet does not lead to biotin deficiency. Ix. Pantothenic acid. Pantothenic acid is a component of coenzyme A, which functions in the transfer of acyl groups, figure 17. Coenzyme A contains a thiol group that carries acyl compounds as activated thiol esters. Examples of such structures are succinyl-CoA, fatty acyl-CoA, and acetyl-CoA. Pantothenic acid is also a component of fatty acid synthase. Eggs, liver, and yeast are the most important sources of pantothenic acid, although the vitamin is widely distributed. Pantothenic acid deficiency is not well characterized in humans, and no RDA has been established. A. Structure of vitamin A. Vitamin A is often used as a collective term for several related biologically active molecules, figure 18. The term retinoids includes both natural and synthetic forms of vitamin A that may or may not show vitamin A activity. 1. A primary alcohol containing a beta-ionone ring with an unsaturated side chain. Retinol is found in animal tissues as a retinol ester with long-chain fatty acids. 2. Retinol. This is the aldehyde derived from the oxidation of retinol. Retinol and retinol can readily be interconverted. 3. Retinoic acid. This is the acid derived from the oxidation of retinol. Retinoic acid cannot be reduced in the body, and, therefore, cannot give rise to either retinol or retinol. 4. Beta-carotene. Plant foods contain beta-carotene, which can be oxidatively cleaved in the intestine to yield 2 molecules of retinol. In humans, the conversion is inefficient, and the vitamin A activity of beta-carotene is only about 1/6 that of retinol. B. Absorption and transport of vitamin A. 1. Transport to the liver. Retinol esters present in the diet are hydrolyzed in the intestinal mucosa, releasing retinol and free fatty acids, figure 19. Retinol from esters and from the cleavage and reduction of carotenes is reesterified to long-chain fatty acids in the intestinal mucosa and secreted as a component of chylomicrons into the lymphatic system, see figure 19. Retinol esters contained in chylomicrons are taken up by, and stored in, the liver. 2. Release from the liver. When needed, retinol is released from the liver and transported to extrahepatic tissues by the plasma retinol binding protein, RBP. The retinol RBP complex attaches to specific receptors on the surface of the cells of peripheral tissues, permitting retinol to enter. Many tissues contain a cellular retinol binding protein that carries retinol to sites in the nucleus where the vitamin acts in a manner analogous to steroid hormones. C. Mechanism of action of vitamin A. Nucleic acid binds with high affinity to specific receptor proteins present in the nucleus of target tissues, such as epithelial cells, figure 20. The active retinoic acid receptor complex interacts with nuclear chromatin to stimulate retinoid-specific RNA synthesis, resulting in the production of specific proteins that mediate several physiologic functions. For example, retinoids control the expression of the keratin gene in most epithelial tissues of the body. The specific retinoic acid receptor proteins are part of the superfamily of transcriptional regulators that includes the steroid and thyroid hormones and 1,25-dihydroxycholecalciferol, all of which function in a similar way. D. Functions of vitamin A. 1. Visual cycle. Vitamin A is a component of the visual pigments of rod and cone cells. Rhodopsin, the visual pigment of the rod cells in the retina, consists of 11 cis-retinal specifically bound to the protein opsin. When rhodopsin is exposed to light, a series of photochemical isomerizations occurs, which results in the bleaching of the visual pigment and release of all trans-retinal and opsin. This process triggers a nerve impulse that is transmitted by the optic nerve to the brain. Regeneration of rhodopsin requires isomerization of all trans-retinal back to 11 cis-retinal. Trans-retinal, after being released from rhodopsin, is isomerized to 11 cis-retinal, which spontaneously combines with opsin to form rhodopsin, thus completing the cycle. Similar reactions are responsible for color vision in the cone cells. 2. Both. Animals deprived of vitamin A initially lose their appetites, possibly because of keratinization of the taste buds. Bone growth is slow and fails to keep pace with growth of the nervous system, leading to central nervous system damage. 3. Reproduction. Retinol and retinol are essential for normal reproduction, supporting spermatogenesis in the male and preventing fetal resorption in the female. Retinol is active in maintaining reproduction and in the visual cycle, but promotes growth and differentiation of epithelial cells. Thus, animals given vitamin A only as retinoic acid from birth are blind and sterile. 4. Maintenance of epithelial cells. Vitamin A is essential for normal differentiation of epithelial tissues and mucus secretion. D. Distribution of vitamin A. Meat, cream, butter, and egg yolk are good sources of preformed vitamin A. Yellow and dark green vegetables and fruits are good dietary sources of the carotenes, which serve as precursors of vitamin A. E. Requirement for vitamin A. The for adults is 1,000 retinol equivalents, Re for males and 800 Re for females. 1 Re equals 1 mg of retinol, 6 mg of beta-carotene, or 12 mg of other carotenoids. F. Clinical indications. All chemically related, retinoic acid and retinol have distinctly different therapeutic applications. Retinol and its precursor are used as dietary supplements, whereas various forms of retinoic acid are useful in dermatology. 1. Dietary deficiency. Vitamin A, administered as retinol or retinol esters, is used to treat patients deficient in the vitamin. Figure 21. Night blindness is one of the earliest signs of vitamin A deficiency. The visual threshold is increased, making it difficult to see in dim light. Prolonged deficiency leads to an irreversible loss in the number of visual cells. Severe vitamin A deficiency leads to xerophthalmia, a pathologic dryness of the conjunctiva and cornea. If untreated, xerophthalmia results in corneal ulceration and, ultimately, in blindness because of the formation of opaque scar tissue. The condition is most frequently seen in children in developing tropical countries. Over 500,000 children worldwide are blinded each year by xerophthalmia caused by insufficient vitamin A in the diet. 2. Acne and psoriasis. Dermatologic problems such as acne and psoriasis are effectively treated with retinoic acid or its derivatives, see Figure 21. Mild cases of acne, Duryea disease, and skin aging are treated with topical application of tretinoin, all-trans-retinoic acid, as well as benzoyl peroxide and antibiotics. Note, tretinoin is too toxic for systemic administration and is confined to topical application. In patients with severe recalcitrant cystic ache unresponsive to conventional therapies, the drug of choice is isotretinoin 13-cis-retinoic acid administered orally. 3. Prevent chronic disease. Populations consuming diets high in beta-carotene show decreased incidence of heart disease and lung and skin cancer, see Figure 21. Consumption of foods rich in beta-carotene is also associated with reduced risk of cataracts and macular degeneration. In clinical trials, beta-carotene supplementation not only did not decrease the incidence of lung cancer, but actually increased cancer in individuals who smoke. Subjects in a clinical trial who received high doses of beta-carotene unexpectedly had increased death due to heart disease. 6. Toxicity of retinoids. 1. Vitamin A. Excessive intake of vitamin A produces a toxic syndrome called hypervitaminosis. Amounts exceeding 7.5 mg per day of retinol should be avoided. Hypervitaminosis are reflected in the skin, which becomes dry and pruritic, the liver, which becomes enlarged and can become cirrhotic, and in the nervous system, where a rise in intracranial pressure may mimic the symptoms of a brain tumor. Pregnant women particularly should not ingest excessive quantities of vitamin A because of its potential for causing congenital malformations in the developing fetus. 2. Isotretinoin. The drug is teratogenic and absolutely contraindicated in women with childbearing potential unless they have severe, disfiguring cystic acne that is unresponsive to standard therapies. Pregnancy must be excluded before initiation of treatment, and adequate birth control must be used. Prolonged treatment with isotretinoin leads to hyperlipidemia and an increase in the LDL-HDL ratio, providing some concern for an increased risk of cardiovascular disease. 11. Vitamin D. The D vitamins are a group of sterols that have a hormone-like function. Active molecule 1,25-dihydroxycholecalciferol 1,25-DOD3 binds to intracellular receptor proteins. The 1,25-DOD3 receptor complex interacts with DNA in the nucleus of target cells in a manner similar to that of vitamin A, see Figure 20, and either selectively stimulates gene expression or specifically represses gene transcription. The most prominent actions of 1,25-DOD3 are to regulate the plasma levels of calcium and phosphorus. A. Distribution of vitamin D. 1. Ergocalciferol vitamin D2 found in plants, and cholecalciferol vitamin D3 found in animal tissues, are sources of preformed vitamin D activity, Figure 22. Ergocalciferol and cholecalciferol differ chemically only in the presence of an additional double bond and methyl group in the plant sterol. 2. Endogenous precursor, 7-dehydrocholesterol, an intermediate in cholesterol synthesis, is converted to cholecalciferol in the dermis and epidermis of humans exposed to sunlight. Preformed vitamin D is a dietary requirement only in individuals with limited exposure to sunlight. B. Metabolism of vitamin D. 1. Formation of 25-DOD3. Vitamins D2 and D3 are not biologically active, but are converted in vivo to the active form of the D vitamin by two sequential hydroxylation reactions, figure 23. The first hydroxylation occurs at the 25 position, and is catalyzed by a specific hydroxylase in the liver. The reaction, 25-hydroxycholecalciferol, 2,5-OH-D3, is the predominant form of vitamin D in the plasma and the major storage form of the vitamin. 2,5-HD3 is further hydroxylated at the 1 position by a specific 25-hydroxycholecalciferol 1 hydroxylase found primarily in the kidney, resulting in the formation of 1,25-dihydroxycholecalciferol 1, 25-DOD3. This hydroxylase, as well as the liver 25-hydroxylase, employs cytochrome P450, molecular oxygen, and NADPH. 2. Regulin of 25-hydroxycholecalciferol 1 hydroxylase, 1, 25-DOD3 is the most potent vitamin D metabolite. Its formation is tightly regulated by the level of plasma phosphate and calcium ions, figure 24. 2-hydroxycholecalciferol 1 hydroxylase activity is increased directly by low plasma phosphate or indirectly by low plasma calcium, which triggers the release of parathyroid hormone PTH. Hypocalcemia caused by insufficient dietary calcium thus results in elevated levels of plasma 1, 25-DOD3. 1-hydroxylase activity is also decreased by excess 1, 25-DOD3, the product of the reaction. C. Function of vitamin D. The overall function of 1, 25-DOD3 is to maintain adequate plasma levels of calcium. It performs action by 1. Increasing uptake of calcium by the intestine, 2. Minimizing loss of calcium by the kidney, and 3. Stimulating resorption of bone when necessary, see figure 23. 1. Effect of vitamin D on the intestine, 1. 25-DOD3 stimulates intestinal absorption of calcium and phosphate. 1. 25-DOD3 enters the intestinal cell and binds to a cytosolic receptor. 1. 25-DOD3 receptor complex then moves to the nucleus where it selectively interacts with the cellular DNA. As a result, calcium uptake is enhanced by an increased synthesis of a specific calcium-binding protein. Thus, the mechanism of action of 1, 25-DOD3 is typical of steroid hormones. 2. Effect of vitamin D on bone. 1. 25-DOD3 stimulates the mobilization of calcium and phosphate from bone by a process that requires protein synthesis in the presence of PTH. The result is an increase in plasma calcium and phosphate. Thus, bone is an important reservoir of calcium that can be mobilized to maintain plasma levels. D. Distribution and requirement of vitamin D. Vitamin D occurs naturally in fatty fish, liver, and egg yolk. Milk, unless it is artificially fortified, is not a good source. D. Distribution and requirement of vitamin D. Vitamin D occurs naturally in fatty fish, liver, and egg yolk. Milk, unless it is artificially fortified, is not a good source of the vitamin. The RDA for adults is 5 mg cholecalciferol, or 200 international units IU of vitamin D. E. Clinical indications. 1. Nutrition. Rickets. Vitamin D deficiency causes a net demineralization of bone, resulting in rickets in children and osteomalacia in adults, figure 25. Rickets is characterized by the continued formation of the collagen matrix of bone, but incomplete mineralization, resulting in soft, pliable bones. In osteomalacia, demineralization of pre-existing bones increases their susceptibility to fracture. Insufficient exposure to daylight and/or deficiencies in vitamin D consumption occur predominantly in infants and the elderly. Vitamin D deficiency is more common in the northern latitudes, because less vitamin D synthesis occurs in the skin as a result of reduced exposure to ultraviolet light. No, the RDA of 200 IU per day, which corresponds to 5 UG of cholecalciferol, may be insufficient, because higher doses of 800 IU per day have been shown to reduce the incidence of osteoporotic fractures. 2. Rickets renal osteodystrophy. This disorder results from chronic renal failure and, thus, the decreased ability to form the active form of the vitamin. 1. 25-DO-cholecalciferol calcitriol administration is effective replacement therapy. 3. Hypoparathyroidism. Lack of parathyroid hormone causes hypocalcemia and hyperphosphatemia. These patients may be treated with any form of vitamin D, together with parathyroid hormone. F. Toxicity of vitamin D. Vitamin D is the most toxic of all vitamins. Like all fat-soluble vitamins, vitamin D can be stored in the body and is only slowly metabolized. High doses 100,000 IU for weeks or months can cause loss of appetite, nausea, thirst, and stupor. And calcium absorption and bone resorption results in hypercalcemia, which can lead to deposition of calcium in many organs, particularly the arteries and kidneys. 12. Vitamin K. The principal vitamin K is in the post-translational modification of various blood clotting factors, in which it serves as a coenzyme in the carboxylation of certain glutamic acid residues present in these T ions. Vitamin K exists in several forms, for example, in plants as phylloquinone or vitamin K1, and in intestinal bacterial flora as menaquinone or vitamin K2. For therapy, a synthetic derivative of vitamin K, menadione, is available. A. Function of vitamin K. 1. Formation of oxyglutamate. Vitamin K is required in the hepatic synthesis of prothrombin and blood clotting factors 2, 7, X, and X. These proteins are synthesized as inactive precursor molecules. Formation of the clotting factors requires the vitamin K-dependent carboxylation of glutamic acid residues, figure 26. This forms a mature clotting factor that contains Y-carboxyglutamate GLA and is capable of subsequent activation. The reaction requires a CO2, and the hydroquinone form of vitamin K. The formation of GLA is sensitive to inhibition by dicumaroy, an anticoagulant occurring naturally in spoiled sweet clover, and by warfarin, a synthetic analog of vitamin K. 2. Interact thrombin with platelets. The Gla residues of prothrombin are good chelators of positively charged calcium ions, because of the two adjacent, negatively charged carboxylate groups. Prothrombin calcium complex is then able to bind to phospholipids essential for blood clotting on the surface of platelets. Attachment to the platelet increases the rate at which the proteolytic conversion of prothrombin to thrombin can occur, figure 27. 3. Role of Y-carboxyglutamate residues in other proteins. Gla is also present in other proteins, for example, osteocalcin of bone, unrelated to the clotting process. However, the physiologic role of these proteins in the function of vitamin K in their synthesis is not yet understood. B. Distribution and requirement of vitamin K. Vitamin K is found in cabbage, cauliflower, spinach, egg yolk, and liver. There is also extensive synthesis of the vitamin by the bacteria in the gut. There is no RDA for vitamin K, but 70 to 140 rag per day is recommended as an adequate level. The lower level assumes 1/2 of the estimated requirement comes from bacterial synthesis, whereas the upper figure assumes no bacterial synthesis. C. Clinical indications. 1. Deficiency of vitamin K. A true vitamin K deficiency is unusual because adequate amounts are generally produced by intestinal bacteria or obtained from the diet. If the protein in the gut is decreased, for example by antibiotics, the amount of endogenously formed vitamin is depressed, and can lead to hypoprothrombinemia in the marginally malnourished individual, for example, a debilitated geriatric patient. This condition may require supplementation with vitamin K to correct the bleeding tendency. In addition, certain second-generation cephalosporins, for example, cefoperazone, cefamandole, and moxilactam cause hypoprothrombinemia, apparently by a warfarin-like mechanism. Consequently, their use in treatment is usually supplemented with vitamin K. 2. Deficiency of vitamin in newborn. Newborns have sterile intestines and cannot initially synthesize vitamin K because human milk provides only about 1/5 of the daily requirement for vitamin K. It is recommended that all newborns receive a single intramuscular dose of vitamin K as prophylaxis against hemorrhagic disease. Detoxicity of vitamin K. Prolonged administration of large doses of vitamin K can produce hemolytic anemia and jaundice in the infant, due to toxic effects on the membrane of red blood cells. 13. Vitamin E. The E vitamins consist of 8 naturally occurring tocopherols, of which Y-tocopherol is the most active, figure 28. The primary function of vitamin E is as an antioxidant in prevention of the non-enzymic oxidation of cell components, for example, polyunsaturated fatty acids, by molecular oxygen and free radicals. A. Distribution and requirements of vitamin E. Vegetable oils are rich sources of vitamin E, whereas liver and eggs contain moderate amounts. The RDA for tocopherol is 10 mg for men and 8 mg for women. Vitamin E requirement increases as the intake of polyunsaturated fatty acid increases. B. Deficiency of vitamin E. Vitamin E deficiency is almost entirely restricted to premature to infants. When observed in adults, it is usually associated with defective lipid absorption or transport. The signs of human vitamin E deficiency include sensitivity of erythrocytes to peroxide, and the appearance of abnormal cellular membranes. C. Clinical indications. Vitamin E is not recommended for the prevention of chronic disease, such as coronary heart disease or cancer. Clinical trials using vitamin E supplementation have been uniformly disappointing. For example, 6 in the alpha-tocopherol, beta-carotene cancer prevention study trial who received high doses of vitamin E, not only lacked cardiovascular benefit but also had an increased incidence of stroke. Detoxicity of vitamin E. Vitamin E is the least toxic of the fat-soluble vitamins, and no toxicity has been observed at doses of 300 mg per day. Unit 2. Cellular Organization. Institute for Advanced Studies B7 Saraswati Nagar. A1. Membrane structure. Cell membranes are crucial to the life of a cell. The plasma membrane encloses the cell, defines its boundaries, and maintains the essential differences between the cytosol and the extracellular environment. In the membranes of the endoplasmic reticulum, Golgi apparatus, mitochondria, and other membrane-bounded organelles in eukaryotic cells maintain the characteristic differences between the contents of each organelle and the cytosol. Membranes, established by the activities of specialized membrane proteins, can be used to synthesize ATP, to drive the transmembrane movement of selected solutes, or, in nerve and muscle cells, to produce and transmit electrical signals. In all cells, the plasma membrane also contains proteins that act as sensors of external signals, allowing the cell to change its behavior in response to environmental cues. These protein sensors, or receptors, transfer information rather than ions or molecules across the membrane. Differing functions. All biological membranes have a common general structure. Each is a very thin film of lipid and protein molecules, held together mainly by non-covalent interactions. Some membranes are dynamic, fluid structures, and most of their molecules are able to move about in the plane of the membrane. The lipid molecules are arranged as a continuous double layer about 5 nanometers thick. This lipid bilayer provides the basic structure of the membrane and serves as a relatively impermeable barrier to the passage of most water-soluble molecules. Protein molecules, dissolved in the lipid bilayer, mediate most of the other functions of the membrane, transporting specific molecules across it, for example, or catalyzing membrane-associated reactions, such as ATP synthesis. In plasma, some proteins serve as structural links that connect the membrane to the cytoskeleton and/or to either the extracellular matrix or an adjacent cell, while others serve as receptors to detect and transduce chemical signals in the cell's environment. As would be expected, cell membranes are asymmetrical structures. The lipid and protein compositions of the outside and inside faces differ from one another in ways that reflect the different functions performed at the two surfaces of the membrane. Membrane ultrastructure and fluid mosaic model. This model, most forcefully proposed by S. J. Singer, A.R. Biochem. 1974, 43, 805-826, is the currently most favored model. Some consider it the sixth most current modification of the original Danieli-Davidson model. It proposes 1. A phospholipid bilayer with the hydrophobic nonpolar fatty acid chains directed inwards and the polar hydrophilic heads lining the surfaces. 2. Proteins, glycoproteins, lipoproteins, associate with the inner and outer surfaces of the membranes. The polar portions of the proteins associate with the polar surface and may protrude from it, while portions of the proteins may be embedded in the bilayer of lipid. It is proposed that the nonpolar portions of these proteins associate with the nonpolar fatty acid chains. Proteins having both polar and nonpolar areas, residues, are termed amphipathic. 3. Under physiological conditions, the membrane components are not rigidly fixed, but exist in a fluid and dynamic state. Lipids membrane are fluid at physiological temperatures, thus there may be fluid movement of the lipid molecules and lateral movement, diffusion, of the proteins that are embedded in the membrane. Protein icebergs in a sea of lipid. Singer, this forms a heterogeneous mosaic of proteins which may be continuously rearranged but often with specificity. 4. Not only is there lateral mobility of lipids, but there is also exchange from one monolayer of the bileaflet to the other monolayer. This exchange flip-flop is much slower than the lateral exchange, detected by nuclear resonance studies. This process is facilitated by specific proteins, enzymes called flipases. 5. Proteins may be integral or peripheral, probably most being integral and displaying various different secondary and tertiary forms. The proteins, being capable of secondary, tertiary, and quaternary structure changes in response to stimuli, may reorient in relation to the phospholipids bilayer. 6. In a phospholipid bilayer, the long fatty acyl side chains in each leaflet are oriented toward one another, forming a hydrophobic core. The polar head groups line both surfaces. 7. The phospholipid layer forms the basic structure of all biomembranes, which also contain proteins, glycoproteins, cholesterol and other steroids, and glycolipids. Presence of specific sets of membrane proteins permits each type of membrane to carry out distinctive functions. 8. All cellular membranes line closed compartments and have a cytosolic and an exoplasmic face. The symmetry of biological membranes is reflected in the specific orientation of each type of integral and peripheral membrane protein with respect to the cytosolic and exoplasmic faces. The presence of glycolipids exclusively in the exoplasmic leaflet also contributes to membrane asymmetry. 9. Most integral proteins and lipids are laterally mobile in biomembranes. According to the fluid mosaic model, the membrane is viewed as a two-dimensional mosaic of phospholipid and protein molecules. 10. As the bilayer is heated, it undergoes a phase transition from a gel-like to a more fluid state over a short temperature range. 11. Cholesterol is a major determinant of bilayer fluidity, although its effect depends on the composition of a membrane. Natural biomembranes generally have a fluid-like consistency, and cells adjust their phospholipid composition to maintain bilayer fluidity. 12. In all cells, proteins in the plasma membrane selectively absorb nutrients, expel wastes, and maintain the proper intracellular ionic composition. Proteins in the plasma membrane anchor the membrane to intracellular cytoskeletal fibers in the extracellular matrix or cell wall. In multicellular organisms, plasma membrane proteins also act in the interactions and communication between cells, which are critical for proper functioning of multicellular tissues. 13. In the cell wall, which is built mainly of cellulose, is a major determinant of cell shape and imparts rigidity to cells. Animal cells, which lack a wall, are surrounded by an extracellular matrix consisting of collagen, glycoproteins. A2. Membrane proteins. 1. Transmembrane proteins. Membrane proteins are either extrinsic or intrinsic. Extrinsic membrane proteins are entirely outside of the membrane, but are bound to it by weak molecular attractions, ionic, hydrogen, and or van der Waals bonds. Intrinsic membrane proteins, the class we are mainly interested in, are embedded in the membrane. Many of them extend from one side of the membrane to the other and are referred to as transmembrane proteins. Cells are constantly pumping ions in and out through their plasma membranes. In fact, more than half the energy that our bodies consume is used by cells to drive the protein pumps in the brain that do nothing else but transport ions across plasma membranes of nerve cells. How can ions be transported across membranes that are effectively impermeable to them? Cells contain proteins that are embedded in the lipid bilayer of their plasma membranes and extend from one side of the membrane through to the other. Such transmembrane proteins can function to affect ion transport in several ways. But how can they cope with the energetically highly unfavorable situation in which an ion must pass through the hydrophobic inner layers of the plasma membrane? 2. Domains. If we examine the detailed structures of many transmembrane proteins, we see that they often have three different domains, two hydrophilic and one hydrophobic. A hydrophilic domain consists of hydrophilic amino acids, at the N-terminus is poking out in the extracellular medium. A hydrophobic domain in the middle of the amino acid chain, often only 20 to 30 amino acids long, is threaded through the plasma membrane, and a hydrophilic domain at the C-terminus protrudes into the cytoplasm. The transmembrane domain, because it is made of amino acids having hydrophobic side chains, exists comfortably in the hydrophobic inner layers of the plasma membrane. Because transmembrane domains anchor many proteins in the lipid bilayer, these proteins are not free-floating and cannot be isolated and purified biochemically without first dissolving away the lipid bilayer with detergents. Indeed, much of the washing we do in our lives is necessitated by the need to solubilize proteins that are embedded in lipid membranes using detergents. 3. Glycoproteins. For reasons well understood, many transmembrane proteins are glycoproteins in the sense that sugar side chains are covalently attached to their hydrophilic domains that protrude into the extracellular membrane. A typical mammalian cell may have several hundred distinct types of glycoproteins studding its plasma membrane. Each of these glycoproteins will have its extracellular domain glycosylated with a complex branching bush of sugar residues covalently linked to the asparagine side chains. Some glycoproteins may have 2 or 3 asparagine-linked sugar side chains, others may have dozens. 4. Multi-membrane spanning proteins. An elaboration of this scheme depicting membrane proteins having single transmembrane domains involves certain membrane proteins that have multiple transmembrane domains. As one sends along the amino acid sequence of these proteins, it becomes apparent that hydrophilic domains, i.e. having hydrophilic amino acids, alternate with hydrophobic domains. The protein chain as a whole when embedded in the plasma membrane actually weaves back and forth between opposite sides of the plasma membrane. Some think such proteins have the configuration of snakes and hence term them serpentine membrane proteins. A commonly used structure seen in many hundreds of serpentine transmembrane proteins involves 7 hydrophobic domains inserted into the plasma membrane separated by hydrophilic regions that are looped out alternatively into either the cytoplasm or the extracellular space. A3. Membrane transport mechanism and ion pumps. All cells acquire the molecules and ions they need from their surrounding extracellular fluid, ECF. There is an unceasing traffic of molecules and ions in and out of the cell through its plasma membrane. Examples: glucose Na+, Ca2+. In eukaryotic cells, there is also transport in and out of membrane-bounded intracellular compartments such as the nucleus, endoplasmic reticulum and mitochondria. Examples: proteins, mRNA, Ca2+, ATP. And charged solutes are small enough and lipid-liking they can move down their concentration gradients directly across the lipid bilayer itself by simple diffusion. Examples of such solutes are ethanol, carbon dioxide, and oxygen. Another difficulty which the membranes pose for some molecules is that the lipid bilayers are not permeable to ions such as Na+, Ca2+, called cations because when subjected to an electric field they migrate toward the cathode, the negatively charged electrode Cl, HCO3 called anions because they migrate toward the anode, the positively charged electrode. Small hydrophilic molecules like glucose and macromolecules like proteins and RNA. But we all know that that cell is intelligent enough to solve the above challenge posed by the membrane. This is how it solves the problem. Passive and active mechanisms move molecules across membrane. Passive transport moves molecules across membrane without expenditure of energy by cell, includes diffusion and facilitated transport. Transport uses energy, ATP, to move molecules across a plasma membrane, include active transport, exocytosis, endocytosis, and pinocytosis. Passive transport. Cell membranes help organisms maintain homeostasis by controlling what substances may enter or leave the cells. Some substances such as water, oxygen, and carbon dioxide can cross the cell membrane without any input of energy by the cell. Movement of such substances across the membrane is known as passive transport. The cell membrane is said to be selectively permeable. The difference in the concentration of molecules across a space is called a concentration gradient. If these molecules diffusing across the membrane from an area of high concentration to an area of low concentration were water molecules, the process would be called osmosis. Water also moves from a low solute concentration to a high solute concentration. The two types of passive transport are transport by simple diffusion and osmosis-facilitated diffusion, carrier proteins and ion channels. 1. Diffusion and osmosis. 1. In diffusion, molecules move from higher to lower concentration, i.e., down their concentration gradient. A solution contains a solute, usually a solid, and a solvent, usually a liquid. In the case of a dye diffusing in water, dye is a solute and water is the solvent. 2. Membrane chemical and physical properties allow only a few types of molecules to cross by diffusion. Lipid-soluble molecules, e.g., alcohols, diffuse. Lipids are membrane's main structural components. Gases readily diffuse through lipid bilayer. Movement of oxygen from air sacs alveoli to blood and lung capillaries depends on concentration of oxygen in alveoli. 3. Osmosis is the diffusion of water across a differentially permeable membrane from its higher concentration to lower concentration. Osmotic pressure is hydrostatic pressure, on site of membrane with higher solute concentration, produced by water diffusing to that side of membrane. 4. Tonicity is strength of a solution in relationship to osmosis, determines movement of water into or out of cells. Isotonic is where the relative solute concentration of two solutions are equal. Hypotonic is where a relative solute concentration of one solution is less than another solution. Hypertonic is where a relative solute concentration of one solution is greater than another solution. 2. Facilitated diffusion of ions. Facilitated diffusion of ions takes place through proteins, or assemblies of proteins, embedded in the plasma membrane. These transmembrane proteins form a water-filled channel through which the ion can pass down its concentration gradient. The transmembrane channels that permit facilitated diffusion can be opened or closed. They are said to be gated. Some types of gated ion channels. 2.1 Ligand-gated ion channels. Many ion channels open or close in response to binding a small signaling molecule or ligand. Ion channels are gated by extracellular ligands, some by intracellular ligands. In both cases, the ligand is not the substance that is transported when the channel opens. External ligands. External ligands bind to a site on the extracellular side of the channel. Examples: acetylcholine, ACH. The binding of the neurotransmitter acetylcholine at certain synapses opens channels that admit Na+ and initiate a nerve impulse or muscle contraction. Butyric acid, GABA. Binding of GABA at certain synapses, designated GABAA, in the central nervous system admits Cl ions into the cell and inhibits the creation of a nerve impulse. Internal ligands. Internal ligands bind to a site on the channel protein exposed to the cytosol. Examples: second message, like cyclic AMP GAMP and cyclic GMP CGMP, regulate channels involved in the initiation of impulses in neurons responding to odors and light respectively. ATP is needed to open the channel that allows chloride Cl and bicarbonate HCO3 ions out of the cell. This channel is defective in patients with cystic fibrosis. Liberated by the hydrolysis of ATP is needed to open the channel. This is not an example of active transport. The ions diffuse through the open channel following their concentration gradient. 2.2 Mechanically gated ion channels. Examples: sound waves bending the cilia-like projections on the hair cells of the inner ear open up ion channels leading to the creation of nerve impulses that the brain interprets as sound. Mechanical deformation of the cells of stretch receptors opens ion channels leading to the creation of nerve impulses. 2.3 Voltage gated ion channels. In so-called excitable cells like neurons and muscle cells, some channels open or close in response to changes in the charge measured in volts across the plasma membrane. Example, as an impulse passes down a neuron, the reduction in the voltage opens sodium channels in the adjacent portion of the membrane. This allows the influx of Na+ into the neuron and thus the continuation of the nerve impulse. 3. Facilitated diffusion of molecules. Small, hydrophilic organic molecules, like sugars, can pass through cell membranes by facilitated diffusion. Once again, the process requires transmembrane proteins. In some cases, these, like ion channels, form water-filled pores that enable the molecule to pass in or out of the membrane following its concentration gradient. Examples. Maltoporin. This homotrimer in the outer membrane of E. coli forms pores that allow the disaccharide maltose and a few related molecules to diffuse into the cell. The plasma membrane of human red blood cells contain transmembrane proteins that permit the diffusion of glucose from the blood into the cell. Glucose transporters: 5 different GLUT proteins and 2 types that co-transport Na and glucose. These are used for secondary active transport. Water channels: 8 different types of aquaporins transport water across membrane. Note that in all cases of facilitated diffusion through channels, the channels are selective, that is, the structure of the protein admits only certain types of molecules through. Whether all cases of facilitated diffusion of small molecules use channels is yet to be proven. Some molecules are passed through the membrane by a conformational change in the shape of the transmembrane protein when it binds the molecule to be transported. 2. Active transport. Active transport is the pumping of molecules or ions through a membrane against their concentration gradient. It requires a transmembrane protein, usually a complex of them, called a transporter, and energy. The source of this energy is ATP. The energy of ATP may be used directly or indirectly. 1. Direct active transport. Some transporters bind ATP directly and use the energy of its hydrolysis to drive active transport. 2. Indirect active transport. Other transporters use the energy already stored in the gradient of a directly pumped ion. Direct active transport of the ion establishes a concentration gradient. When this is relieved by facilitated diffusion, the energy release can be harnessed to the pumping of some other ion or molecule. Direct active transport. 1. The Na+ ATPase. The cytosol of animal cells contains a concentration of potassium ions K+ as much as 20 times higher than that in the extracellular fluid. Conversely, the extracellular fluid contains a concentration of sodium ions, Na+, as much as 10 times greater than that within the cell. These concentration gradients are established by the active transport of both ions. And, in fact, the same transporter, called the Na+ K+ ATPase, does both jobs. It uses the energy from the hydrolysis of ATP to actively transport 3 Na+ ions out of the cell for each 2 K+ ions pumped into the cell. This accomplishes several vital functions. It helps establish a net charge across the plasma membrane, with the interior of the cell being negatively charged with respect to the exterior. This resting potential prepares nerve and muscle cells for the propagation of action potentials leading to nerve impulses and muscle contraction. The accumulation of sodium ions outside of the cell draws water out of the cell and thus enables it to maintain osmotic balance, otherwise it would swell and burst from the inward diffusion of water. The gradient of sodium ions is harnessed to provide the energy to run several types of indirect pumps. The crucial roles of the Na+ K+ ATPase are reflected in the fact that almost 1/3 of all the energy generated by the mitochondria in animal cells is used just to run this pump. 2. The H+ K+ ATPase. The parietal cells of your stomach use this pump to secrete gastric juice. Transport protons H+ from a concentration of about 4x 10^8 m within the cell to a concentration of about 0.15 m in the gastric juice, giving it a pH close to 1. Small wonder that parietal cells are stuffed with mitochondria and uses huge amounts of energy as they carry out this 3 million-fold concentration of protons. 3. The Ca2 ATPase of skeletal muscle. In resting skeletal muscle, there is a much higher concentration of calcium ions, Ca2+, in the sarcoplasmic reticulum than in the cytosol. Activation of the muscle fiber allows some of this Ca2+ to pass by facilitated diffusion into the cytosol, where it triggers contraction. After contraction, this Ca2+ is pumped back into the sarcoplasmic reticulum. This is Ca2+ ATPase that uses the energy from each molecule of ATP to pump 2 Ca2+, exchanging them for 2 or 3 protons, H+. Pumps are designated p-type ion transporters because they use the same basic mechanism, a conformational change in the proteins, as they are reversibly phosphorylated by ATP. And all 3 pumps can be made to run backward. That is, if the pumped ions are allowed to diffuse back through the membrane complex, ATP can be synthesized from ADP and inorganic phosphate. 4. ABC transporters. ABC ATP binding cassette. Transporters are transmembrane proteins that expose a ligand binding domain at one surface and a ATP binding domain at the other surface. The ligand binding domain is usually restricted to a single type of molecule. The ATP bound to its domain provides the energy to pump the ligand across the membrane. The human genome contains 48 genes for ABC transporters. Some examples. CFTR, the cystic fibrosis transmembrane conductance regulator. TAP, the transporter associated with antigen processing. The transporter that liver cells use to pump salts of bile acids out into the bile. ABC transporters that pump chemotherapeutic drugs out of cancer cells, thus reducing their effectiveness. ABC transporters must have evolved early in the history of life. The ATP binding domains in archaea, eubacteria, and eukaryotes all share a homologous structure, the ATP binding cassette. 2. Secondary indirect active transport, company transport. Antiport systems, indirect active transport, also termed as co-transport, uses the downhill flow of an ion to pump some other molecule or ion against its gradient. The driving ion is usually sodium, Na+, with its gradient established by the Na+ K+ ATPase. Besides ATP-powered pumps, cells have a second, discrete class of proteins that import or export ions and small molecules, such as glucose and amino acids, against a concentration gradient. These proteins use the energy stored in the electrochemical gradient of Na plus or H plus ions to power the uphill movement of another substance, a process called cotransport. 1. Symport. In this type of indirect active transport, the driving ion, Na plus, and the pumped molecule pass through the membrane pump in the same direction. Example 1. Na plus linked symporters import amino acids and glucose into many animal cells. Many cells, such as those lining the small intestine and the kidney tubules, need to concentrate glucose against a very large concentration gradient. Such cells utilize a 2 Na plus 1 glucose symporter, a protein that couples transmembrane movement of one glucose molecule to the transport of 2 Na plus ions. Na plus glucose transporter is used to actively transport glucose out of the intestine and also out of the kidney tubules and back into the blood. Example 2. The Na plus iodide transporter. This symporter pumps iodide ions into the cells of the thyroid gland for the manufacture of thyroxine and also into the cells of the mammary gland to supply the baby's need for iodide. 2. Anti-cell uses movement of an ion across a membrane and down its concentration gradient to power the transport of a second substance, uphill, against its gradient. In this process, the two substances move across the membrane in opposite directions. Example 1. Na plus linked antiporter exports Ca2 plus from cardiac muscle cells. Is one of the best cation antiporter system. The membrane of cells contains one or more types of antiporters, which couple movement of a co-transported ion, often Na plus, down its electrochemical gradient to movement of a different molecule in the opposite direction against a concentration gradient. In cardiac muscle cells, for example, a Na plus Ca2 plus antiporter, rather than a plasma membrane Ca2 plus ATPase, plays the principal role in maintaining a low concentration of Ca2 plus in the cytosol. It will be interesting to see how the following two drugs work. The drugs Wabayan and digoxin increase the force of heart muscle contraction and are widely used in the treatment of congestive heart failure. The primary effect of these drugs is to inhibit the Na plus K plus ATPase, thereby raising the intracellular Na plus concentration and lowering intracellular K plus. Plus Ca2 plus antiporter functions less efficiently with a lower Na plus concentration gradient. Fewer Ca2 plus ions are exported and the intracellular Ca2 plus concentration increases. This increase causes the muscle to contract more strongly. Example 2. AE1 protein, a Cl-HCO3 antiporter, is crucial to CO2 transport by erythrocytes. In addition to cation antiporters, which transport only positive ions, many cells also contain anion transporters, which transport only negative ions. An important example is A1 protein, the predominant integral protein of the mammalian erythrocyte. This anion antiporter catalyzes the one-for-one exchange of Cl and HCO3 across the plasma membrane. So one singly charged negative ion is exchanged for another, there is no net movement of electric charge and the reaction is not affected by the membrane potential. Thus, the direction of the reaction is dependent only on the concentration gradients of the transported ions. Transmembrane anion exchange is essential to an important function of the erythrocyte, the transport of waste carbon dioxide, CO2, which is generated in peripheral tissues, to the lungs for excretion by respiratory exhalation. Waste CO2 released from cells into the capillary blood diffuses across the erythrocyte membrane. In its gas form, CO2 dissolves poorly in aqueous solutions, such as the cytosol or blood plasma, but the potent enzyme carbonic anhydrase inside the erythrocyte converts CO2 to the water-soluble bicarbonate, HCO3, anion. The from hemoglobin in fact, the peripheral capillaries induces a conformational change in the globin polypeptide that enables a histidine side chain to bind the proton produced by the carbonic anhydrase reaction. The HCO3 formed by carbonic anhydrase is transported out of the erythrocyte in exchange for an entering Cl via A1 protein. The overall direction of this anion exchange process is reversed in the lungs. CO2 diffuses out of the erythrocyte and is eventually expelled in breathing. Lower concentration of CO2 within the cytosol drives the carbonic anhydrase reaction, as written above, from right to left. HCO3 reacts to yield CO2 and OH. At the same time, oxygen binding to hemoglobin causes a proton to be released from hemoglobin. The proton combines with the O to form H2O. The lowered intracellular HCO3 concentration causes HCO3 to enter the erythrocyte in exchange for Cl. Example 3. Several cotransporters regulate cytosolic pH. Aerobic metabolism of glucose yields lactic acid, and aerobic metabolism yields CO2, which is hydrated by carbonic anhydrase to carbonic acid H2-CoNe3. Nucleic acids dissociate, yielding H plus ions protons. If these protons were not exported from cells, the cytosolic pH would drop precipitously, endangering cellular functioning. Two types of cotransport proteins are employed to remove some of the excess protons generated during metabolism of animal cells. One is HCO3 Cl cotransporter, which imports one Na plus ion down its concentration gradient, together with one HCO3, in exchange for export of one Cl ion against its concentration gradient. The imported HCO3 ions combine with protons generated by metabolism to produce CO2, which diffuses out of the cell. Thus the overall action of this transporter raises the cytosolic pH, reduces the H plus concentration. Also important in removing excess protons is a Na plus H plus antiporter, which couples entry of one Na plus ion into the cell down its concentration gradient to export one H plus ion. Plasma membranes of most animal cells also contain a Na plus independent Cl HCO3 antiporter similar to the erythrocyte A1 protein discussed previously. This anion exchange protein functions to lower the cytosolic pH, in effect removing excess O ions. Recall that a HCO3 ion can be viewed as a complex of O and CO2, so export of HCO3 lowers the cytosolic pH. Exchange of cytosolic HCO3 for extracellular Cl is powered by the import of Cl down its concentration gradient, Cl out greater than Cl in. The activity of these antiport proteins depends on pH, providing cells with a fine-tuned mechanism for controlling the cytosolic pH of proton-exporting transporters, which are activated when the pH of the cytosol falls, act to raise the cytosolic pH. Similarly, a rise in pH above 7 Stimulates the Cl-HCO3 antiporter, leading to a more rapid export of HCO3 and decrease in the cytosolic pH. In this manner the cytosolic pH of growing cells is maintained very close to pH 7.4. Small changes in the cytosolic pH may have profound effects on the overall cellular metabolic rate. For instance, cells grown to maximal density confluence in tissue culture generally become quiescent.